Hello, everyone, and welcome to KKISH Global Education Forum. Today, we're delighted to have Dr. Rajeev Muni. Dr. Rajeev is from St. Michael's Hospital in Toronto, Canada, and he's the assistant professor and vice chair of the Clinical Research Department of Ophthalmology and Vision Science in the University of Toronto. Uh, Dr. Rajeev has a lot of experience with cases of pneumatic retinopexy, and he had a lot of publication in this subject. He was also been training a lot of our colleagues that were from Saudi Arabia and from the Gulf region, and he has very good relationship with our region. So we're very delighted to have you, Dr. Rajeev, and the mic is yours.
Great, thank you, Adele. It's really an honor to be speaking to all of you today. This is one of the unanticipated benefits of COVID has been that, we're more connected than ever because, I think it's very unlikely I'd be giving a talk in Saudi Arabia right now if it wasn't for the Zoom and the ability to do this. So it's very nice to be able to reach out to you. And like Adele said, we've had so many fellows from the Gulf region, and we have such a good relationship with them forever, after they train. And so it's really an honor to speak to ophthalmologists in that region. Today, I'm going to talk to you about retinal detachment repair, which is one of my favorite topics to discuss. I think it's why most of us go into surgical retina in the beginning. When you see that you can do something to fix the retina, it's an amazing experience, enlightening experience, and that captures many of us, and that's why we choose this specialty. And I know that's what really drew me to it. And today, I'm going to talk to you about a paradigm shift in retinal detachment repair. And, I know that a lot of what I'm going to say is probably very different than how you treat your retinal detachments. And, so today I'm asking that you keep an open mind. And because of the differences in how we all treat, if you go from one part of the world to another, or even one center to another, it's completely different. You'll get a vit buckle in one place, you'll get a pneumatic in the other, you'll get a scleral buckle in one place, and it's completely different. And this is the reason why we chose to study this area, because the fact that there's so many treatments just tells you that there's many ways to fix a retinal detachment, and they all probably work more or less. And, we want to look at more subtle differences between them to see, is there a difference in certain types of patients? So I'm going to start by just showing you this case here. And, this is a case, a very typical scenario. 3 months post-op, I did a vitrectomy, the retina is attached, patient's 20/25, and I tell the patient, you've done great, everything is good, the retina is fully attached, you're seeing 20/25, you were MAC off before, and you don't need to see me anymore. But the patient looks at me and, they say, well, no, I have a big problem here. I can't see well. I see double, I see distorted, everything, your head looks smaller than the rest of your body. I can't use both eyes at the same time. And so there's a disconnect in what we see and what we tell our patients and what they're experiencing. And I think that's one of the biggest messages for today that I want you to take away from this. So let's look a little bit more carefully at this patient. So first of all, we can measure the vertical and horizontal distortion, and you see that the vertical and horizontal distortion score of 0.4 is a moderate distortion, and the patient has significant anisoconia. So at 24, it goes up to 30. Anisoconia is a significant discrepancy. So this patient has significant image size difference, and this makes his eye, his 20/25 eye, useless to him from a binocular perspective. And so this patient will tell you that he did not have a successful outcome, even though to us, the patient has had a successful outcome. And this is kind of an example of a patient. So this is a patient, another one, who had a macula off, retinal detachment, superior break, 12 o'clock, as you can see, and there's some lattice inferiorly. And 2 weeks following a pneumatic retinopexy, the retinal break is attached, the retina is attached, the patient has done well. And in our experience in Toronto, doing lots of pneumatic retinopexies, what we've always been surprised at is how well the patients see after. the patients, the way I think of pneumatic retinopexy is kind of going back in time. The bubble can block the tear and allow the fluid to reabsorb. And it's like going back in time to when you had just the retinal tear. And when you have a retinal tear, we don't do surgery, we do laser for that. And so that's why we put a bubble to go back in time to when you just have a tear. And then we do laser retinopexy to treat the tear. And we're always surprised at how these patients react, and many of them act as if nothing's been done to their eye, as if you know those patients you see follow up horseshoe tear, they have those types of outcomes. And so there's a disconnect between what the whole world typically does for retinal detachment surgery and perhaps what the outcomes are. And so as we all know, minimally invasive vitrectomy surgery is the way to fix most things retina right now, and it has to do with these amazing machines that we have that have cut rates of 15,000 and 20,000. The machines keep getting better. We have small gauge instruments, and it's really an elegant and efficient way to treat retinal detachments. But that said, there hasn't been a single trial that's shown a benefit of vitrectomy over scleral buckle or pneumatic retinopexy from a functional outcome for retinal detachment repair. And so is convenience and the ease and the elegance of the technique is one thing, but the functional outcomes for patients is another thing. And so we undertook a randomized clinical control trial to answer this question. What is better from a visual perspective, from distortion perspective, from a visual function questionnaire perspective for patients undergoing pneumatic retinopexy versus vitrectomy? And we randomized almost 200 patients to these treatments. Now, the patients had to meet certain specific criteria, which we'll talk about later. But in summary, the PIVOT trial showed that patients who had pneumatic retinopexy had significantly better visual acuity at every time point by up to 10 letters at 3 and 6 months and about 4 to 5 letters at 1 year. And just to give you an idea, when we looked at the outcomes with Lucentis or aflibercept, we're seeing those kind of changes, 7 or 8 letters difference. So this is a mean difference. Some patients do much, much better than 5 letters, and some patients may have the same outcomes as vitrectomy. But on average, there's a 5-letter ETDRS improvement. But that, to me, is not the biggest finding in the PIVOT trial. This is the biggest finding in the PIVOT trial. It's that when you undergo pneumatic retinopexy, you have less vertical metamorphopsia with pneumatic compared to vitrectomy. Never has there been a way or a documented way of minimizing distortion until now. This study has shown us that not only do people get vertical distortion less with pneumatic, but also the severity of the vertical distortion is less. And so it makes you wonder why. Why is there a difference between vitrectomy and pneumatic retinopexy from this perspective? And if you look, this is the proportion. So you see there's about a 20% more patients have distortion in the vitrectomy group. So the first thing we did is we looked at the OCTs. So if you look at the OCT, we found that patients who had vitrectomy had significantly more disruption of the outer retinal layers compared to pneumatic retinopexy. And we're still doing more detailed analysis, and we'll be publishing this soon. But there was some suggestion that the integrity of how the retina reattaches is different between the two groups, as shown from randomized clinical trial data. So let's go back now and look at that patient. This is the one on the left who had the vitrectomy, and I'm going to show you another patient on the right who had a pneumatic retinopexy. They both look good, 20/20, 20/25, it's the same thing more or less. And the patients are both seeing well from a visual acuity perspective. But now let's look a little bit deeper. That patient who was 3 months post-op that I showed you, if you look very carefully on the fundus autofluorescence imaging, we see that there's what we call a retinal vessel printing. And this signifies the location of where the retinal vessel was before the vitrectomy compared to where it is now. And you can see that there's been a change or a movement of that vessel. And I'm going to show you more examples. But basically, a light bulb basically went off when we saw this, because we realized that perhaps the differences in functional outcomes that we're seeing have some relation to this phenomenon of retinal displacement. And could there be a difference between the two treatments? And not surprisingly, when you have less displacement, the OCT findings also tend to be better. So you have less disruption of the outer retinal layers. So let's look at the patient who had pneumatic retinopexy. And if we look at their fundus autofluorescence, they had no vertical and horizontal distortion, no anisoconia. And in this specific case, there was no displacement of the retina. The autofluorescence is pristine, showing us that the retina has been reopposed as close as possible to its original location compared to the case of vitrectomy that I showed you. And not surprisingly, the OCT showed a better integrity of the outer retina. So the first point that I want you to take home today is when you look into the eye and you say that the retina is attached and everything looks good, and you tell your patient that you've done a good job and that they're doing well, it's not exactly accurate. Anatomic reattachment is not enough for you to call it a success. For me to call it a success, not only does the retina have to be attached, but you also have to have no significant displacement of the retina, and you should have good functional outcomes. That is what we call success. This is another patient who has a retinal vessel printing. You can see very prominent inferior displacement of the retinal vessels following vitrectomy surgery. So this historical focus of primary reattachment rate, I want to do the procedure that's going to reattach the retina. That is an older concept now, and we have to think differently about functional outcomes. What's giving patients the best possible visual outcome? So anatomic reattachment, I think of as the bottom of the pyramid. That's the most basic requirement, but you also need to have microstructural and macrostructural integrity of the anatomic reattachment so that you know that you've done as good of a job putting the retina back in place. And this will lead to better functional outcomes for patients. So the next study that we did after the PIVOT trial, along with our colleagues at Newcastle and in Hamilton, it was a multi-center retrospective study where 238 eyes from different centers who have different ways of treating retinal detachments were followed. And at 3 months, we obtained fundus autofluorescence imaging. And guess what? The proportion of patients with retinal displacement was 44.4% in vitrectomy versus 7% with pneumatic retinopexy. And this number of 44.4% is very consistent in the literature. There's been several studies that have shown similar rates of retinal displacement, and it always ends up in that 40 to 50% range. So now we know that we have two different treatments that have different integrity of anatomical reattachment. If you do this procedure, vitrectomy, you're going to have a much higher risk of displacing the retina versus in pneumatic retinopexy. And we coined these terms called Hera and Lyra. Hera means a high integrity retinal attachment, which is what you get when you do pneumatic retinopexy more often. And Lyra, or low integrity retinal attachment, is more common with vitrectomy. This is another example of a profound case of retinal displacement where you can clearly see that the retina has been shifted inferiorly and temporally in a case where we use perfluorocarbon liquid. And this would be an example of Lyra. Now let's go back to the basic mechanism about why. Why is this happening with vitrectomy surgery? So here I'm showing you an animation. And at the end of surgery, we know that there's significant subretinal fluid often, even if it's microscopic amounts. And as the patient positions and lifts their head after surgery, we see that the retina gets that fluid has a bulk flow to the periphery. And as fluid flows under a thin membrane, take your hand and pass it under any thin membrane, like a bed sheet or a tissue paper or something. You'll see that there's stretching that's occurring. And this is what we believe is causing the stretching due to the large buoyant force of a large gas bubble in vitrectomy surgery. And here's another cross-sectional video showing that as the fluid gets displaced to the periphery, this point here gets stretched or displaced due to that flow of fluid. And this is occurring because of the buoyant force or the contact force of the bubble in vitrectomy acting over a larger area than you get with pneumatic retinopexy and with a larger force because of the size of the bubble. Now, let's compare that to pneumatic retinopexy. We inject a very small bubble into the vitreous cavity. There's much less significant force being applied by that bubble to the retina. we like to do steamrolling to reduce the amount of fluid under the retina, but that final retinal reattachment is not occurring because of the large bubble pushing the fluid somewhere else. It's the natural reabsorption of fluid by the RPE pump, and that leads to a more natural settlement of the retina. It allows the photoreceptors to interdigitate nicely with the RPE, and this is why we believe that the functional outcomes are better with pneumatic retinopexy. You know, we always talk about this wallpaper analogy, and we want to put the wallpaper back on as best we can in retinal detachment. But it's not enough just to put it on and it's wrinkled and it's distorted, and that's not a good job. You want to do a good job where you put the wallpaper back on nice and smoothly. And this is the paradigm shift that we have to have in our specialty, where it's not enough just to say that it's attached. In conclusion, pneumatic first line had better visual acuity and metamorphopsia results from a randomized controlled trial. There are several studies now. We've done another one that's a prospective study that we haven't published yet, but that have demonstrated that pneumatic retinopexy is associated with a high integrity retinal attachment, and you just cannot get those numbers with vitrectomy. Anatomic success requires you to also have Hera, and the concept of integrity is now going to lead to modifications in vitreoretinal surgical techniques, in my opinion, which will lead to better functional outcomes for our patients. Thank you very much, and that is the end of my first talk.
Thank you very much, Rajeev. I really appreciate that you took it in this matter, because the second talk is where I think a lot of people will be interested to have a discussion. So I'm going to leave the discussion to the end. I just want to remind everyone that the floor is open for any questions that you can post here. And we're going to share at the end some of the experience of new adopters of pneumatic retinopexy. And I think it would be interesting if the audience also give their take on that. You're welcome to start your second talk.
Thank you, Adele. So, you know, now that I've hopefully convinced you to try pneumatic retinopexy, if you haven't, now I'm going to go over a discussion about how best to do pneumatic retinopexy. And before we start, you know, I should tell you, I've met Adele through this chat group that we have. It's a global chat group for pneumatic retinopexy, and we have about 70 doctors from all over the world. And today, actually, a few of them will be later presenting some of their first cases. And so you can talk to Adele or email me, and we will add you to the group, because what's very unique about that group is that people who have never done pneumatic retinopexy can basically post photos or their case, and you almost get live feedback from very experienced people who've done pneumatic retinopexy. So it's almost like being in fellowship, and you know, someone telling you step by step what to do. And so we have a very great group for that, and I welcome you all to join if you're interested. So I'm going to talk about the indications and the case selection. Then we're going to talk about surgical technique, managing complications, and vitrectomy after failed pneumatic, which does happen. So we need to know how to deal with that. So let's start by basically saying, if you are starting doing pneumatic retinopexy, what is the standard criteria? So Paul Turnambi, the late Paul Turnambi, did the pneumatic retinopexy trial, and he identified patients who had a single break or multiple breaks within 1 clock hour of detached retina. Now, he, in his trial, did not allow any pathology in attached retina. And that to us was something that was very limiting, because almost all patients have some lattice, or they might have some atrophic hole or other tear in attached retina. And so this was the standard criteria, but we moved beyond that in the pivot trial. So we included patients, again, in detached retina. They had to have breaks within 1 clock hour. However, you could have extensive lattice degeneration, even 360 lattice. You could have multiple breaks, even large breaks in attached retina. That was allowed within the trial. And what we do is we treat those patients with laser retinopexy before we inject the gas bubble, and then we inject the gas bubble and position the patient. Now, these are what we call extended criteria. So these are patients who had breaks that are inferior to 8 o'clock, or multiple breaks spanning multiple quadrants. Now, when you've done thousands of pneumatics, you know how to do these cases, but I don't necessarily recommend this to be your first case. You know, these are cases that after you're comfortable with the technique, you can achieve high success rates. But we have not yet published on the randomized data for these types of cases, as the trial is still ongoing. So I can't convincingly tell you that it's better to do this, but we do pneumatics on these types of cases at this time. So I'd like to show you my technique.
Read about it in a very old book.
So this is a step-by-step technique. So the first thing. So the first thing we do is we do a topical anesthetic or topical lidocaine. And the next step is an anterior chamber paracentesis. So here what we're doing is we're applying, using the needle, it's a 30 gauge needle on a TB syringe. And we are basically entering inferiorly over iris. And I use the plunger for constant pressure, and we express as much fluid as we can. Then we mark about 4 millimeters posterior to the limbus, and you always want to inject superiorly. And we add a 0.3 to what we took out, and we inject 0.6 cc's of SF6 if we took out 0.3. Then we want to look at the eye. We want to make sure that the central retinal artery is perfused and visualized, and that the pressure is under control. Now, sometimes, again, we have to re-tap afterwards to lower the pressure. So I'm using the plunger for counter pressure, and with the plunger removed, I'm allowing fluid to go back into the syringe. Again, I recheck to make sure that the central retinal artery is perfused. And then we give the patient a prescription for drops. Usually we use prednisone and antibiotics for about 5 days. So this is that patient that I just showed you who I did the pneumatic retinopexy on. Now, if you look at the top left, you see 2 hours after just putting the patient face down, the retina is now mostly reattached. And then you can see at 24 hours, it's almost completely reattached. And we were able to get serial optos photos so we can document the very rapid resolution. This is the power of the RPE pump. Robert Mockamer, who basically developed vitrectomy, once said that the retina wants to reattach. All you have to do is not do too much to it. And so that to me means a lot, because it's telling us that, let the RPE pump reabsorb and the fluid, and let the RPE pump do the work. All you have to do is close the brakes somehow. And so here you can see at 1 week and 2 weeks, there's a complete reattachment of the retina. Now, what gases do we use? My preference is to use sulfur hexafluoride gas for several reasons. Number one, it expands very quickly. C3F8 takes 4 days to reach its maximal size. By using a gas bubble that expands fast, you can determine if pneumatic retinopexy is going to work. If you have to wait 4 days to reach the maximal gas bubble size, you've waited 4 days to really get to the point where then you can say, okay, now let's see if the bubble is going to be big enough and if it'll work. So I like the fact that SF6 expands quickly. The other thing is, in a non-vitrectomized eye, if you have a large gas bubble of C3F8 there for 38 days, I worry about the possibility of getting additional retinal breaks. And so I like the fact that sulfur hexafluoride expands quickly, it's in and it's out. Once the job is done, you don't need it anymore. And it's good that it reabsorbs fast in about 12 days. Now, when you inject gas into the eye, there's a few tips here. You want to take a 3 cc syringe with pure SF6 gas with a 30 gauge needle. You enter through the pars plana so that the tip is halfway in, and then you pull back so that the tip is barely in. And so what you're doing here is you're pulling it back and then injecting the gas bubble into this ever expanding bubble. And that allows you to maintain one bubble so that you don't get fish eggs, which is what you want to avoid. I very strongly believe in the steamrolling maneuver. So you have to put the patient face down initially for 6 hours if they're macula off and 4 hours if they're macula on. And then you raise their head 30 degrees every hour. And what this does is it expresses fluid through the retinal brake so that the overall amount of fluid that's there to be displaced and that's there to be reabsorbed by the RPE pump is less. We instruct the patients to use topical steroids and antibiotics for a week. We position for about 9 to 10 days, as much as possible. I usually tell them as 23 out of 24 hours a day, as much as you can, maintain the position. I know that not all patients will do that. And even if they do a lot less, usually it works. But the more they position, the higher you're putting the odds in their favor. We want to ensure that the patient and the family understands the importance of positioning. And this is really critical. You know, it's interesting. One thing when I give talks about pneumatic retinopexy, people say, oh, you know, in my country, no one will do this. It's impossible. You know, no patient is going to position. They won't listen to instructions. They won't show up. And, you know, in Canada, we have a very multicultural population, people from all over the world. And it's amazing how patients will do whatever you advise them. They want the best outcomes for themselves. And so I encourage you, if you spend time, you talk to them, you explain to them what's going on and why this will lead to a better outcome, patients will buy in and they'll do it. You want to tell people to avoid lying on their back. So this is an example of a case where you had a superior RD, you had a break at 3 o'clock. So we lasered that break before firsthand, we put 3 rows around it. Then we inject the gas bubble and we position the patient head elevated. And then we lasered those breaks. This is another video where I'm going to show you another case of some other factors or other kind of aspects of how I perform pneumatic retinopexy. And so again, it's a superior retinal break. We position the patient initially, and I actually show them how I want them to position. So I show them face down, then I show them 30 degrees for every hour, and I'm explaining this to the wife so that she understands what the patient needs to do. The patient came back the next day, the retina was mostly reattached. There was some residual fluid, which is not uncommon after pneumatic retinopexy. On that day, I did laser retinopexy to that superior retinal break, and then I followed the patient over time. With laser retinopexy, you can use subconjunctival anesthesia, and that kind of helps. And sometimes it's over a couple of days that you have to do the laser. But here you can see a nice big bubble, an attached retina, and this patient did very well. And here you can see the laser through the gas bubble. I'm going to now show you some other cases of what I would call extreme pneumatics. These are pneumatics that I would recommend when you have significant experience, but we do very commonly in Canada. So this is a 15-year-old boy with a max splitting detachment from 9 to 2 o'clock with a dialysis, a superior dialysis. And this usually would be treated with scleral buckle by most people. However, we know for several reasons, pneumatic retinopexy in these types of cases, when there's no PVR, works very well in children. You know, some retinal surgeons will say in a pediatric detachment, all you have to do is touch the eye and it goes away. And it's true because the RPE pump is so strong. As soon as you close the brake with any mechanism, basically, the retina reattaches because that RPE pump is so powerful. And so we know that in children, pneumatic retinopexy works very well. And this is the next day you see that the retina is fully attached, and at several days later, it remained attached. This is another case, a bullous inferior retinal detachment, but a temporal retinal break. We injected the gas bubble at 10:27 in the morning. At 1:44, you see that the bullous inferior detachment is much better. It's almost attached. And the next day you see, the same day at 3:37, it was better. And the next day it was fully reattached. We lasered the retinal break. This is another case where many would not consider. They say, oh, there's an inferior detachment. There could be some other pathology. As long as you do a careful preoperative examination and identify the location of the retinal break, it doesn't matter where the fluid is. It's all about the location of the retinal break. The RPE pump will do the rest of the work. What about this case? A patient who has a bullous nasal retinal detachment in a young myopic female. You can see that there's a horseshoe tear here, very posterior. So we injected a gas bubble, and on the same day at 1:43, we see a significant improvement. And at 4:10, the same day, again, an improvement. And by the next day, fully attached, we lasered that nasal retinal break, and the patient did very well, never requiring any surgery. Now, what about complications? With any good procedure, we know that we can get complications. And part of being the art of pneumatic retinopexy is really understanding how to deal with those complications. So the worst thing that can happen, one of the worst things, is that you get subretinal gas. And you can generally avoid this by avoiding fish eggs. So you want to try to get one single large gas bubble in order to prevent these bubbles from going under the retina. The reason a large gas bubble doesn't go under the retina is because of the property of surface tension. Surface tension creates an elastic film-like layer on the surface of the bubble, and that prevents it from going under the retina. This is an example where you get lots of fish eggs. Now, usually it's not a problem, actually. If you get fish eggs, often they will coalesce over the first 24 hours. We usually tell patients, if you get a lot of fish eggs, to stay face down for the first full day. And then we have them come back and we see that the bubbles have coalesced. Most of the time with the regular sized retinal breaks, it's very rare, even with fish eggs, that it'll go under the retina, but sometimes it can. And if that happens, then you can try to use a depressor and to milk the bubbles out through the retinal break. And if that doesn't work, if there's small bubbles and they're away from the break, it's not a problem. The only time that it is a problem is if you have significant gas opening up the tear and causing the retina to not reattach. And in that case, you need to do a vitrectomy. There's also something called prehyaloidal gas, or the space of Petit, which is a little space between the anterior hyaloid and the eye wall. If you inject the gas by chance in this area due to an anterior placement of the needle, you can sequester the gas bubble in this space. Very rarely that can lead to large tears, but most of the time, if you put the patient face down, it'll break through the anterior hyaloid face and it'll go to the back of the eye. You know, I would say this happens once every 3-4 years, and we do, you know, hundreds and hundreds of pneumatics. So it's very rare, but when it occurs, usually the prone positioning will be sufficient. Very rarely would I say you'd have to do a vitrectomy or do something to remove the gas bubble. Now, persistent subretinal fluid is this is where again, the art of pneumatic retinopexy comes in. You know, we commonly see persistent subretinal fluid in cases of chronic detachments. And the important thing about persistent subretinal fluid, you have to ask yourself one question: is the fluid getting better? Is it getting worse? Or is it staying the same? If it's getting better or it's staying the same, you should never proceed to surgery. In fact, it can be more complicated because you have to then create a retinotomy to drain the fluid, and now you're creating inferior retinotomies, which is not what you want to do. The only time you proceed with surgery for a failed pneumatic is when you're convinced that the fluid is getting worse. If the fluid is getting worse, then you know that there is an open break somewhere, and that's when you should do surgery. So it's important to do a careful examination to identify new breaks. Now, sometimes you might be surprised that, you know, this patient had a total RD, and let's say there was a supratemporal retinal break, and I tamponaded that break, and there's still fluid, and I've lasered the break. Well, I look around, now I see a nasal break, a new nasal break that wasn't there or that I missed. And now I can reposition the patient. Sometimes I can add a gas bubble, and then you can attach it. So you can sometimes salvage the situation, but sometimes when there's worsening fluid and you don't see the cause of it, or you see an inferior break, then you proceed with surgery. And this is another important point. One way to get in trouble with pneumatic retinopexy, people have said, oh, I've seen bad outcomes when I've tried. It's because when you have a failure, you wait too long to repair it. Once you have a failure, you treat it like something that has to be done relatively soon. I would suggest that within 72 hours is optimal. Waiting a week after a failed pneumatic is one way to get in trouble. I'm now going to show you a video about vitrectomy after pneumatic retinopexy. So one of the important things in a phakic patient, you don't want the patient lying on their back, even in the pre-op area, even for half an hour or 45 minutes. You want them to, you tell them to be face down until the second that they see you in the OR, because the nurse will often say, oh, lie on your back, let me put the IV in. And before you know it, it's been an hour on their back and you've lost your view through the lens. The first thing you want to do is you try to clear the vitreous from the cannulas and try to remove the gas bubble that way. If that doesn't work, then you go into the bubble with the vitrector and make sure that you're always keeping the cutter in the bubble so that you never touch the lens. Then we do a very careful 360 peripheral vitrectomy with scleral indentation, because the bubble can sometimes compress the vitreous and you want to avoid PVR situations. So you want to do a careful peripheral shave in all patients undergoing vitrectomy. This patient happened to have an inferior retinal break, which we treated with endodiathermy, and we drained through that retinal break, and then we reattached the retina. And the rest of the vitrectomy is pretty standard. So really the main thing is the careful 360 vitrectomy and avoiding contact of the bubble with the lens. This is the downside of doing this in a hospital. I just.
No, that's fine. I think we hear you fine.
Okay. Okay.
So really appreciate you took the time during this busy day.
What's that? Yeah, we'll take just a second here to a break, but I'm gonna go over some of the myths about pneumatic retinopexy, because this is kind of one of those things where this is one of those situations where you'll get a lot of opinions about pneumatic retinopexy, and a lot of those things don't pan out when you look at the actual data.
I hope it's not something serious.
Yeah. It's funny, there hasn't been this many announcements in the last month, and within this 20 minutes, we've had 3 announcements. Okay. Are you able to still hear me talk, or?
Yeah, I can hear you. You can carry on. I hope that you can, it's not really bothering you.
No, it's okay. It's okay. So one of the common myths is pneumatic retinopexy does not work as you do not relieve the vitreous traction on the brake. So that's true. We're not doing anything to relieve the traction on the horseshoe tear. However, we know that when we see patients who have horseshoe tears, we don't do vitrectomy for that. We don't do buckle for that. So the concept that you're not relieving traction is not a sufficient reason to not do pneumatic retinopexy, because we know that for retinal tears, we don't need to relieve traction. And like I was saying, pneumatic retinopexy is like the bubble going back in time to when you had a retinal tear, and then you're lasering it. So if laser works for a horseshoe tear, it should work for a pneumatic retinopexy. The other thing is that people say that pneumatic retinopexy is not a long-term solution, as the retina will eventually redetach anyway. Well, we know now from 2 randomized control trials, from the Paul Ternambi paper, the pneumatic retinopexy trial, and the pivot trial, with involving almost 500 patients, that there's been no significant redetachment after 3 months. So when we looked at the pivot trial results, there was a 1 to 2% rate of redetachment after pneumatic retinopexy, and a 2 to 3% rate after vitrectomy after the 3-month time point. So you do have a very durable treatment with pneumatic retinopexy. The other common myth is that pneumatics that fail will have a worse outcome. You'll have high risk of PVR, and that patients will lose their vision. We now know from, again, 2 randomized controlled trials that those who fail initial pneumatic still had a good visual acuity outcome, in fact, as good as the primary vitrectomy group. So even when you have a failed pneumatic, you do just as well as having a vitrectomy from the beginning. And that's something that's very important, and important to tell patients, that they haven't lost anything when you have a failed pneumatic. If it works, you have a better outcome, you have less morbidity, you have better visual acuity and visual function results. If it doesn't work, you have the same outcome with a vitrectomy procedure. What about the follow-up? How many visits do these patients need? So in the randomized control trial, patients who had pneumatic retinopexy had about 10.8 visits, versus in vitrectomy, there was 9.6 visits. You have to remember that patients with vitrectomy have worse visual acuity. They get cataracts, they come back and they need to have cataract surgery and post-op visits for their cataract. And so when you add up all the visits, there was a 1 visit extra for pneumatic retinopexy compared to vitrectomy. We also looked at the quality of life overall, their general overall quality of life, and there was no difference between pneumatic retinopexy and vitrectomy. We also looked at the visual function questionnaires, and we just published our results in JAMA, that patients who have pneumatic retinopexy have better visual function in the first 6 months compared to vitrectomy surgery. Now, this is the most common reason people say they don't want to do pneumatic retinopexy. They say they want a higher single operation success rate. They want to do 1 procedure, and they want that to work no matter what, whether the retina is displaced or not displaced, regardless of what the visual acuity is, they want to do 1 procedure. So I want to look at that specific argument more carefully. Let's look at the reattachment rate. It was 93% with vitrectomy and 81% with pneumatic retinopexy. Here we see that the difference in the success rate is 12% of reattachment rate. I shouldn't say success, reattachment. And that difference of 12%, if you look at the number needed to treat, is 8.33. In other words, if you believe in doing less surgery because you don't want failures, and you are suggesting that doing vitrectomy first is the way to go, what you're saying is that you're going to do 8 vitrectomies to save one of those patients from needing a second procedure. So those 7 patients didn't need vitrectomy from the beginning. Only 1 patient really needed a second vitrectomy. And not only that, you're going to expose all of those patients to requiring cataract surgery in their one eye and possibly their other eye if they have the anisometropia. So from a surgery perspective, doing less surgery, pneumatic retinopexy also makes sense. So in conclusion, patients receiving pneumatic retinopexy as first-line treatment have better visual acuity results from randomized controlled trial data, and they have less morbidity compared to patients receiving vitrectomy. And pneumatic, as per the pivot trial criteria, should be considered and offered to patients before vitrectomy in both phakic and pseudophakic patients. And I'm just going to show you this picture again, and I want you to remember this picture. When you see your patient who has retinal reattachment after vitrectomy surgery, get an autofluorescence. And if you're seeing significant retinal displacement, I want you to just think twice about the next time when you see a patient who has a single superior tear and consider doing something less invasive to avoid this outcome.
This is a case of a 69-year-old pseudophakic female.
Now, what is the solution to vitrectomy? I'd like to show this new concept that we just
with a retinal break at 12
have
o'clock.
recently presented at the
patient
AO.
underwent a 23-gauge pars plana vitrectomy with a core vitrectomy, followed by peripheral vitreous shave with 360-degree scleral indentation. Here you can see a 12 o'clock break with scleral indentation. With careful depressed examination inferiorly, we found a retinal break in attached retina, which was treated with endolaser retinopexy. Endodiathermy was then applied to the superior retinal break to assist with subsequent visualization. In this specific case, no air fluid exchange was performed. All cannulas were then removed, and the wounds were closed with 7/0 vicryl suture.
The retina was left detached.
How can we minimize retinal displacement, which is so common after vitrectomy surgery? One approach is to allow the RPE pump to reabsorb the fluid. We performed an anterior chamber paracentesis to remove as much aqueous as we could from the anterior chamber. We then injected 0.6 cc's of pure sulfur hexafluoride gas. Immediately after surgery, the retina was mostly reattached with the face down positioning for 6 hours, followed by steamrolling to the head elevated position. On day 1 postoperatively, the patient underwent laser retinopexy.
The other option is to do cryo
at 4 days
at the time of surgery.
There was no retinal displacement. At 1 month, the retina was attached with a high integrity retinal reattachment and no retinal displacement. Thank you.
So this is our approach. If you need to do a vitrectomy surgery, the problem with vitrectomy that's causing displacement is large gas bubble size. Even if you do a 50% air fluid exchange or a 40%, you still get it. And really what we're working on now is minimizing the size of the gas bubble to the least amount possible. And we're doing a prospective study with this technique involving almost 70 patients where we will be using C3F8, 0.3 cc's, so even the smallest possible volume. And what we believe is that by avoiding a large gas bubble, we can greatly minimize the risk of displacement with vitrectomy surgery in simple detachments. Now, I still would recommend pneumatic retinopexy for many reasons in patients meeting pivot trial criteria, but there's specific situations where I like this approach. For example, a patient with vitreous hemorrhage, and I go in, I remove the vitreous, and I find a single break with a detachment. This is a patient that meets pivot trial criteria, even though they had vitreous hemorrhage and I couldn't see that. So I did the vitrectomy, and now I then convert to pneumatic retinopexy by doing this minimal gas vitrectomy technique. Another example would be a patient where there's no visible break, but under wide field viewing, you can examine and find the little retinal break that caused the detachment, and you see that it's localized. You cryo the break and put a small gas bubble like you do in pneumatic retinopexy. Another example might be where you see a superior break and an inferior break that's suspicious. Oh, maybe there's a break at 6, I'm not sure. You go in and you confirm that there's no inferior break. and only the superior break or the temporal break, or one break is causing the detachment, then you do this to minimize the risk of retinal displacement. There's other examples where you have a small pupil, capsular phimosis, difficult view. Again, you can use this technique. So when patients are not candidates for pneumatic for other reasons, you can often use this technique with vitrectomy to achieve a higher integrity attachment. And so this is now part of my armamentarium for retinal detachment repair, in addition to scleral buckle and vitrectomy and pneumatic retinopexy. So with that, I'm going to end. I'm going to pass it back to Adele. And Adele, we have two or three presenters who have done their first pneumatic retinopexy cases on our chat group. And I also, if you could add, if Mahmoud Al-Rabia and Mustafa Hanout, if they're there, they also, I asked them to kind of help also, as experienced pneumatic. Yeah, if you could add them as the panel, and we can have the three cases and discuss.
Absolutely. So I'm just going to start the first case. It's going to be by Dr. Saud Al-Jani. He's our fellow here, but I'd like you to stop sharing your presentation for him to start.
This is a case of a 16.
Just from share screen, you can just stop sharing from there.
Oh yeah, okay.
The green one. Just pull this.
Okay.
Stop share.
Yeah. Okay.
I
Perfect.
can see.
Yeah.
I'm not sure if I can see Mahmoud. Okay, Dr. Saud, we can hear you now. If you wanna start playing your presentation.
Okay, thank you, Dr. Rajeev, for informative presentation. Thank you, Dr. Adil, for letting me for this opportunity to share my very simple experience with my first case of pneumatic retinopexy. So this is 45 years old female who came with us with LRD macula off for 1 day with division of hand motion. This was her color fundus. As we can see, there was one superior temporal horseshoe tear. Also, if you can see, there is some area of lattice, the superior nasal area. So we were deciding, me and Dr. Adil, whether we go for this patient for pneumatic retinopexy or for parts plan vitrectomy. But we were having some issue. So first of thing, the patient is one ICU nurse, and she said, if I want a surgery, I want it under GA during this era of COVID-19. Plus, she came on the weekends, so we need to have, or we need to wait for two more or 3 days. Plus, she turned out that she's COVID-19 positive. Her husband also is COVID-19 positive. So we were forced to do pneumatic retinopexy. So me and Dr. Adil, we proceed and did for her pneumatic retinopexy. She was last patient in our office at that time, and we proceed pneumatic retinopexy. We saw her after 3 days. Retina was totally attached, no subretinal fluid. So we augmented laser at the superior temporal area, and plus also the superior nasal area here around the lattice. We augmented laser. Then we see her after 14. The retina was totally attached. VA was 20/40, and the patient is happy, and we went fine. So it was very simple procedure, quick. We did less than 5 minutes. I think this could be a perfect solution, or at least temporary solution, this COVID-19 era. And the end was everybody's happy. She was happy. We were happy. Hospital staff and everyone was happy that we did not admit this patient. And this is my simple experience. Thank you, Dr. Adi. Thank you.
Thank you. That's a great example, and it highlights how, in some countries it doesn't matter, but health economics and the access to the OR and utilizing resources is going to become a greater and greater issue for all of us. And I never like to use the cost reason to promote pneumatic retinopexy. I don't think that's the right reason to do it. I strongly believe that I'm doing what's better for patients, that patients are going to get better results. And that's why we do it. But it also has many practicalities, as Saud has very elegantly shown, that, in this era where you want to minimize GA and minimize, operating room usage and allow patients to be done as outpatients outside of a hospital facility, those are great advantages for the pneumatic retinopexy.
I think I have Mustafa on, so if you want to share your thoughts as well. I'm gonna move to Dr. Rodrigo Arana, and he's training in Colombia. He's originally from Bolivia, and he will share one of his cases as well. It's the first case that he's done. So I'm gonna give you the opportunity to share. So can you share your presentation now?
Yes, thank you very much for the opportunity. I will share now my screen. Thanks, Dr. Muni, Dr. Adele, for the opportunity. I'm gonna share my screen. Can you all see my screen?
Yes, quite clear.
Okay, perfect. So I'll go and present this. So this is my very short experience with retinopexy, with pneumatic retinopexy. This is my first case, a 50-year-old male, 1 week progressive vision loss on the left eye. He had hand motion, was best corrected visual acuity, single supranasal horseshoe tear from 10 to 11 clock hours. It was a bullous retinal rhegmatogenous retinal detachment from 9 to 3. So this is a short video showing where the bullous, how bullous was the retinal detachment. This is some pictures from the anterior segment node red reflex and some pictures from the posterior pole. Here we can see a picture of the horseshoe tear. I did cryo first. Then I did an AC tap. I got like 0.3 cc's on the AC tap. After this, I injected SF6, 0.6, 100% gas. I'm gonna just fast forward this so you can see the moment where I'm injecting the gas. Unfortunately, I didn't get any fish eggs, but it was a continuous, a big bubble, a continuous big bubble. So that was good. This is 4 hours after macula was attached. The bullous part of the retinal detachment was better, much better. I did laser 48 hours after the gas bubble. We can see this is a 1 week post-op image. I don't have the Optos, so I had to take pictures very periphery. There's some laser spots and the cryo part, and we had an FAF 1 week after, 15 days after, and showing Hera. And my short second case is...
We'll allow our next speaker to show his case because...
Okay, great. Yeah, perfect.
His first case, exactly. So if you can stop sharing and maybe we can move to Dr. Eber Garagarza from Mexico. He also wants to share his first case as well.
Yeah, I share my screen. So give me a second.
So until okay, we can see it now.
Okay, you can see my screen? Yes. Hi, everyone. Thank you, Dr. Muni, and thank you, Dr. Adel, for the invitation. It's an honor to me to share my first case. A 26 years old woman present with a 3-day history of sudden vision loss on her right eye. She didn't need any trauma. Her medical history is in it, and only she's a contact lens user for myopia. And the examination, the red eye, her vision is hand motion with minus 16 sphere. And the left eye, bad visual acuity to 20/25 with high myopia. And the anterior chamber and the anterior segment was unremarkable. So this is the photo. In this photo, you can see a super retinal detachment that go from 9 o'clock to 20 o'clock. If you see this photo on the other projection, you can see two breaks or two breaks. One for lattice degeneration at 11 o'clock, and the other one at 1 o'clock. As you can see, two minus holes contiguous. You can see the macula was detached. So the left eye, she has some breaks, And this is an OCT through the macula. You can see an detachment, and you can see that she has an PVD from OCT. So we perform a pneumatic retinopexy. We did a week straight 0.3 cc anterior chamber tap, and we inject 0.6 CCSF6 to 100%. Immediately, the patient was face down for the next 6 hours, and then steamroller maneuver. So this is the photo for the first day. You can see a lot of fish eggs, but it was my first case. And at the 3rd day, there are some bubbles, but I could to do laser. And to the day 7, you can see the burn light laser. And in the OCT, you can see that macula is reattached, but you can see some cysts in internal retina and loss of MLE line in this section. This is the photo to the day 30. The photo, you can see the holes all blocked. The retina was fully attached, and if you can see the right image, you can see the autofluorescences from 50-50 grades, and the vision accuracy was 20/70. The OCT more similar to 1 month ago. So you can see some displacement of the retinal vessels. So this is Hera, this is Lyra. The patient says that she has metamorphopsias and necropsias, but the vision is better from the macula. Their macula is attached.
Thank you very much.
Yes.
Thank you for sharing this experience. I appreciate you joining us, Dr. Erber. So
yes, thank you.
We have a lot of questions directed to you, Dr. Muni.
Yes.
And so I'll just start by a simple question by Dr. Abdurrahman Al-Saad. He was asking about what's the role of taking the autofluorescence after 3 months? Is this the time that you actually see those displacements, or?
Yeah, no, the displacement, you can see it much earlier, even at 1 month. It's just, we've picked a standard time frame to get it. The vessel printing, the retinal, we call it retinal vessel printing, will be there for several months, even up to over a year, we know. And so you can see it as soon as you get a view. Now, typically, if you use C3F8 gas or SF6 gas, you know, there's gas in the way. So we've picked 3 months because that's when the C3F8 bubble will be gone. Also, they haven't really developed much of a cataract, and that tends to be when you can get a good image. But with pneumatic retinopexy, you can even do it at 2 weeks. And with our minimal gas vitrectomy technique, we've done it at 1 week. So you can do it anytime. But this is when you're doing research, you want to standardize the protocol. And so we've chosen 3 months as the optimal time from a visualization perspective to get the image.
Questions about the technique. So Dr. Yahya Zahrani is asking about how do you do laser afterwards? Do you do LIO? Do you do just a clamp? And do you recommend doing 360-degree laser or just around the breaks? That you say?
Yeah, so the laser is the hardest part about doing pneumatics. It's what's most challenging, and but it comes very quickly. Usually our fellows after 1 month, they're very good at it. And there's different approaches. One, you want to try to. I like to laser through the bubble, because when you're looking through the bubble, everything is minified and you have a nice clear view often, and so you can laser well. The other option is sometimes if the meniscus is in the way, you can change the head position to move the bubble away from where you want to laser. So you can play around with it and get it. Often on the first day, they're a little bit tender. So I always put patients on prednisone drops 4 times a day so that they have less inflammation. And that allows you to have more comfort so that you can do the laser the next day. But sometimes you have to wait till the 2nd day or the 3rd day to get the laser done. Subconjunctival anesthesia is very helpful. You know, when you're starting out, you know, if you have access to cryo in your clinic, that's also a very good approach for small breaks. For bigger breaks, we prefer laser, and in general, we prefer laser, but cryo makes it very easy because you've already done the treatment around the break and then you inject the bubble. And sometimes we'll supplement with a barricade in addition to that, but there's no pressure to do it because you've already treated the break. You know, those are some of the pearls. The other thing is in pseudophakic patients, you know, if you just lie a patient flat on their back, looking up to the ceiling, you can get a very nice panoramic view through the bubble where you can almost laser like a full 180 degrees with them just in that one position, because the small bubble minifies everything and you get this nice panoramic view there. So it just takes experience, but it's very doable.
Yeah, absolutely. I think this is one reason many people like to do laser under air in a lot of cases. So a question about how you mark the breaks. I mean, preoperatively, do you pre-injection? Is there a special technique that you use, or?
Yes. So first of all, it's, you know, it's going back to doing very careful examinations. You know, we kind of get spoiled with vitrectomy because it doesn't really matter. You'll find everything in the OR, right?
Yeah.
So here you have to go back to the old school way of marking all the breaks and doing a careful diagram so you know where those tears are. So most of the time we can just see the break and treat it. There are two approaches. One, if you have small holes, you can actually crank up the laser power and sear the edges of the break with laser. I don't do that very often. The other technique I find very helpful is to mark the break in the meridian of the break at the aura. So what I do is if the break's at 10 o'clock, I'll depress anteriorly where the aura is and I'll laser right there. So I know which line the break is in, and then I'll laser it. And other times, you know that, okay, the break was around 11 and you can just do a barricade from, you know, 12 to 1 and you can surround that area. So, you know, these are all tricks that you can use. But generally speaking, you know, eventually you get a good view and you can do the treatment, even if it's not on the first day.
And what about doing paracentesis? I saw that you showed you take out around 3 cc's, 0.3. What's your rule in dealing with paracentesis?
Yeah, I mean, I think the AC paracentesis is the most important part of the procedure, actually, because the larger the gas bubble you can put in, the better you're going to get, the greater the chance of achieving retinal reattachment. And so I like to take as much as I can. So I'm very careful. I like to go inferiorly over iris with a 30 gauge needle and a TB syringe. And I put the needle so that it's barely, it's into the aqueous. And I used the opposite side plunger. I took out the plunger from the syringe and I used that to create a dome over the needle. And then I'm applying very firm pressure because not only do I want the aqueous, I also want any liquefied fluid from the back that's like water to come forward. And you can do that. So sometimes I can remove even 0.6 or 0.7 or 0.8 cc's from the anterior chamber. And what we do then is we add 0.3 cc's to that and inject that into the vitreous cavity. The one thing you definitely want to be careful when you're starting out is you want to stay over the iris inferiorly. You enter around like 5 o'clock in a right eye, or, you know, 5 o'clock in a left eye and maybe 7 o'clock in a right eye, so that you can stay inferior over that iris the whole time, because you don't want to nick the lens with the needle. That's one thing to be careful about.
What about pressure issues after the injections? Do you give Diamox routinely? How do you deal with those cases?
Well, we don't give anything. There's no Diamox or drops in 99% of the cases. We will retap if the pressure is, we never check the pressure even, actually. So what we do is we inject the gas, then we look at the central artery. If the artery is open, if it's pulsatile, we know that the pressure is high, and we'll wait 5, 10, 15 minutes. It usually becomes non-pulsatile. And if needed, we'll do an AC tap, a second one. If they're NLP and it's occluded, then we'll do another AC tap, but there's never a rush. You don't have to quickly rush and try to drain the fluid, because the chamber will be shallow, you know, because you already decompressed it and now you put a large bubble in the back. So it's going to make the AC shallow. So you always have time, you know, and you take your time. After five minutes, the AC will be reformed, and then you can go in with the needle. The other tip is when you pull the needle out after doing an AC paracentesis, want to pull the needle very slowly. If you quickly pull the needle out, the iris will come to that location and you can get iris incarceration. So you want to pull the needle very carefully. But once the central artery is patent and it's not pulsatile, you know that the perfusion is fine. And very, very rarely, maybe 1 out of 200 cases, do you have an issue with eye pressure the next day. So it's very unlikely. And as long as they're seeing out of the eye and you see that the artery is perfused, then you're good.
A question from Dr. Susan Wilati. She's saying, although the stretching by large bubble is a plausible concept, how can you not, I think it's extrapolate, the vitreous separation and removal as a cause, if not contributed factor to the retinal replacement, displacement?
Yeah, so, we've done, I can talk about this for hours, retinal displacement. So, if maybe I'll come back and talk about that one time, but, we've done lots of research on why retinal displacement is happening. And very briefly, basically what happens is that the bubble inside the eye applies a buoyant force to the retina. This buoyant force it applies a contact pressure to the retina, causing a bulk flow of fluid inferiorly where there's no gas. And that flow of fluid under the retina is what stretches the retina. The simple process of removing the vitreous does not cause displacement. We do pneumatics in vitrectomized eyes, and now we're doing this minimal gas vitrectomy technique where we're removing the vitreous and using a small bubble, and we're not seeing as much retinal displacement. So we know that simply the vitreous removal aspect is not what's causing this from multiple observations that we've had.
I think the following question is something that you personally like. The question is about retinal displacement following primary scale buckle alone, and if yes, have you compared the rate displacement between scale buckle and pneumatic?
Yeah, that's a great question. So we are doing research on that. We're comparing vit buckles versus buckles, and what makes sense to you is what it is. It's the fact that you don't want to force the fluid to be you don't want to intervene. You want the RPE pump to work. So if you do a non-drainage buckle, you're also not going to get retinal displacement. If you do a small bubble pneumatic, you also have a very low rate of retinal displacement. But scleral buckle from a displacement perspective is almost ideal because you are allowing the RPE pump to drain the fluid. Now, if you drain, then it's a different story. And so we're looking at that in more detail. So the displacement rates with buckle are low. I would say about 12 to 15% in the small data set that we have, but we're still researching that more. But definitely RPE pump based procedures, pneumatic retinopexy, scleral buckle, are superior to vitrectomy from the perspective of retinal displacement.
And what about the question on perfluorocarbon, the belief that using perfluorocarbon would decrease?
Yeah, there's a lot of controversy. I don't know if you want to get into that, but okay. So, the overall experience in the literature is that with perfluorocarbon liquid, you still see very high rates of retinal displacement. And that makes sense to us for a couple of reasons. We experimented with keeping perfluoron in the eye to see what happens when you put PFO. I was saying, the stretch is occurring because of the flow of subretinal fluid under the retina. When you put a heavy liquid on the retina, you're inducing a lot of flow of fluid out through the break. And not surprisingly, that patient I showed you with that very classic example of Lyra, the retina was displaced in the temporal and inferior direction, in the same direction that the breaks were. And so putting the PFO in causes displacement. We know that. Now, when you remove the PFO, we know from intraoperative OCT that you still get significant pockets of subretinal fluid. And so then when you fill the whole eye with gas and the patient sits up or they move around, that fluid is all being pushed by the buoyant force of the bubble to where there's no gas, usually the bottom 1% or 2% of the eye. And that flow of fluid again will cause displacement. So in theory, it doesn't make sense that PFO would help very much, except that if you can eliminate all the fluid, minimize the amount of subretinal fluid, that might help you. There was a randomized control trial comparing PFO versus no PFO, but there were significant methodological issues, and we're not really sure about the validity of that data. And so I think the jury is still out on that one, whether PFO is better or not. We're doing more work on that to try to figure it out. But there's been many case series with hundreds of cases where significant PFO was used, and you're still getting retinal displacement. So,
Dr. Sulaiman, he's about to ask a question. Dr. Sulaiman, the mic is yours.
Sure.
Yeah, thank you, Dr. Rajeev, for the
Thank you.
talk. So, I have a question about the JAMA paper. So you had 44% of patients had retinal displacement with vitrectomy. So this group, they had, I assume that they had various methods of retinal detachment repair in terms of BFO versus no BFO, posterior drainage retinotomy versus peripheral retinotomy. So was subgroup analysis performed? This is one question. The second question, how much of this 44% were symptomatic?
I see. Okay. So the first thing is, yes. So we have the JAMA paper. There's also another paper now with prospective data, and we've confirmed that posterior retinotomy versus drainage through the break does not influence retinal displacement. You get it. And that goes along with our theory about why it's happening by the residual fluid. Now, if you minimize the fluid, probably better with posterior retinotomy, hypothetically, you would get less displacement. But in the numbers that we're talking about, in the 200 to 300 cases, we're not finding a significant result. Maybe if you do 1,000 cases, we'll get something significant. But from the current evidence in that paper and another paper, posterior retinotomy does not help. We just talked about perfluoron, and again, we're not 100% sure whether that reduces it or not. But most series show that even with PFO, you do get it. In the JAMA paper, we had very low rate of PFO, so we can't really comment, but we did have a lot of posterior retinotomy and drainage through the break, and that did not impact. Your second question was the functional outcomes. This is a very complicated question to answer. There's many factors that are affecting the visual acuity and the visual results. Number one, you have the displacement. Number two, you have cataract and other things like that. Number three, even if the retina is not displaced, the interdigitation of the photoreceptors to the RPE may be better when it's naturally being attached with pneumatic retinopexy, which is different than the displacement concept. This is, when you have CSR, for example, patients generally recover all their vision because that bleb of fluid is reabsorbed nicely by the RPE. Why not let the RPE do it? When we drain internally, we're causing that retina to be attached more forcefully. And so that interdigitation may be off. Now, when you put all of this together, in the integrity paper that in JAMA, we found less vertical distortion in the pneumatic group compared to the vitrectomy, in the displaced patients, there was more distortion than those that were not, but it's not convincing yet. And I still think that the findings that all of these patients are symptomatic. They all say, oh, your head looks smaller, things are warped or curved, when is it going to get, but I don't think we have yet a great metric to actually quantify and document that. So when we measure anisoconia, we ask them, does this line look straight or not? And for anisoconia, we're looking at the image size differences. What we're seeing is that there is also in the new data that we have that what would you expect if the retina got stretched? Well, you expect that the photoreceptors are spaced farther apart. And now because they're spaced farther apart, an object is being visualized as smaller because it's covering less photoreceptors. And so we are seeing that there's a trend towards anisoconia more. Like next time you see a patient, they say, oh, everything looks smaller in the eye that you did operated on. That there's a high chance that displacement is contributing. The other thing that I want to point out is that autofluorescence is limited in terms of the resolution that you can use to visualize retinal displacement. You can't tell if a tiny little vessel in the macula has also been displaced. With millions of photoreceptors, even with pneumatic retinopexy, there's probably some micro displacement. We know we've measured the degree of retinal displacement. In pneumatics that have displacement, it's usually about 0.1 millimeters. In vitrectomy, it's much more. It's about 0.3 millimeters. So we haven't solved the problem. You know, going back to the beginning of my talk where I said, you know, we want to get the best functional outcomes. There's still a long way to go. But you know, common sense is that you want the retina back where it was. You don't want it to be in a location that's, you know, 0.5 millimeters away from where it was before. And I think that moving towards minimizing displacement is a step in the direction of better functional outcomes. But, you know, we still can't deal with the fact that, you know, the photoreceptors have had some damage from being macula off and other things that occur with the interdigitation that I was talking about. So a lot of
analogy about this from one of our fellow. He was saying that it's like when you lose weight doing a bariatric surgery and lose a lot of weight quickly, you tend to have those skin issues. So yeah, I like that analogy, so I wanted to share it. So before we move to more practical questions, I want to ask about any value of adaptive optics and this and assessing this.
Yeah, exactly. So we're now we just got the approval, because it's not Health Canada approved the adaptive optics machine here, but we now have obtained Health Canada approval specifically to look at this specific topic. And so what we're doing is we want to look at the cone density and the spacing between cones. And what I'm expecting to find is that when you have those florets of cones, you're going to see increased space between the cones in the macula. And that the jury is still out on that, but we should have some data hopefully within a year on adaptive optics imaging to see if that cone spacing is changed. And I expect that it would be.
So a practical question. Some institution only allows this procedure to be done in the OR. I mean, for different reasons. Do you think if you're going to take the patient to the OR, just do a vitrectomy?
Could you not? You can't do it in the office.
I just want to add something to that. So if you think that this procedure can be done as outpatient, do you think that a surgeon who does pneumatic has to have the setup of a vitrectomy in his facility to be able to do it? Meaning that patient comes to you, you do a pneumatic. If it doesn't work, send it to someone else. Is that something that you can?
So I have my wife, actually, she's a medical retina specialist. So she doesn't do surgery, but she does pneumatics. So, but, I will see her, so you have to have a very good relationship. Maybe not married, but you have to have a good relationship with a surgical retina guy in your back pocket, like someone who is okay with that. But, to be honest, like, pneumatic retinopexy is not easy. It's actually more complicated than doing a vitrectomy, technically speaking. Like, I can sit down and do a 3-port pars plana vitrectomy in my sleep and not have to, worry about lasering through the bubble and this and that. It's much easier and kinder to the surgeon to do a vitrectomy because you don't have to examine thoroughly. You can do it all in the operating room. It's done and that's it. But why are we going to this great length? It's because we want the patients to do better. And in fact, I feel like the skill required to do a pneumatic requires even more training. You need to be extremely good at indirect laser and examining the retina and knowing where all the breaks are and how the fluid moves and all of that. And I do think that it's in the realm of surgical retina. I wouldn't advise like medical retina people who don't do a lot of peripheral retina to just start injecting bubbles. I think that we could get into some problems with bad outcomes that way. So I really believe that it's part of surgical training to do that. The other question about the practicality. Yeah, that's a very good question. I mean, in some countries, they do intravitreal injections in the OR, right? So, I mean, what I would say is the elegance of the procedure is the fact that you can do it outside. You never have to enter the OR. And, if I had to go to great lengths to get into the OR the first time to do a pneumatic, and then if I thought there was a high risk of failure, then bring them back again, yeah, of course, that would impact my decision somewhat for some patients. But what I would do in that situation, I think, is I would have very strict criteria. So use the pivot criteria. If, we know that there's 80% and probably for even stricter criteria where you don't have any other pathology and single break, you probably can get 90%. So, you know, in those cases, even if I had to take them to the OR, why would I do a vitrectomy and cause a cataract and higher risk of displacement if I had a 90% chance of that I thought in my practice, in my hands, of getting the retina attached? So it really depends on your confidence with the procedure and what the chances are of success and how easy it is to get into the OR and all of that. So.
A question or a comment from Dr. Sosan Welati. She says that it seems like it's time to revive the temporary link of balloon. And that should get rid of all of the issues that we're having with displacement.
That's right. Yeah. I mean, I think Linkoff was a very bright man, and, you know, he realized that non-drainage drainage was not necessary, and that, you know, a temporary buckle is a very good approach. So, you know, if someone always says, if it was your eye, what would you want? So Adele, you know, if you had a 12 o'clock detachment, 12 o'clock, let's say a bullous superior detachment with one single break at 12 o'clock, and you look like a young guy, and you were in Toronto, and there's one surgeon, I could do a pneumatic. There was Dr. Devenier who could do a vitrectomy, and there was Dr. Lam who could do a buckle. What would you want?
Well, I think talking for myself, I would be more inclined to do pneumatic. I think,
yeah, because you don't want to have phaco surgery. You don't want to have this implant in your eye all the time. And so if I asked myself, what do I want? If I had a 9 to 3 detachment, any break in the superior clock hour within 1 clock hour, pivot trial, I would want a pneumatic retinopexy. If I had an inferior break, I would want to find someone who does lots of primary buckles and have them do a very localized, either radial sponge or a small segmental buckle. You know, the times are changing now. Going in and doing a huge vitrectomy buckle for a single break at 12 o'clock is not in the best interest of our patients.
I really enjoyed this talk, and I'm sure a lot of our colleagues done. Dr. Sosan says, yeah, she would have the gas bubble as well. So she's our senior, very delightful and very nice colleague, and we really love her here. So I would take this opinion as well. I really thank you for this time. I know that you're in the middle of a clinic, and it's a hectic time for you. I really appreciate you gave it this time. And by this, I think we can conclude our session. And I want to thank you all for being here.
Yes, so, and the last thing I'd like to say, I thank you for the kind invitation, and just take us up on that offer. Let Adele know, you know, we have this very lively group, and you can be involved and do your first cases, you know, so I encourage you to join.
Absolutely. I'll add you to the group as soon as you give me a call or a text.
Very good. Thank you all. Take care. All the best.